All right, so we have disclosures that we're obligated to present to you. Both of us do research for a lot of different companies, and we get support from those companies, so we need to let you know that. So let's start from the very beginning. The first description of XLA was in 1952, so it's actually one of the first primary immunodeficiencies identified. This is kind of the birth of things, and this is the standard stock picture of Ogden Bruton, an Army physician who treated a little boy who continued to have pneumonias. He had an 8-year-old, he saw this child at 8 years old. He had a history of bone infections, sepsis, which is infection of the body, bunch of pneumonias caused by pneumococcus, and this is the pre-Prevnar and pre-Pneumovax days, so nobody was vaccinated for pneumococcus. And before he was sick, this child was considered to be a completely normal, healthy child. He had childhood illnesses, he had chickenpox, and then measles, and then got sick after the measles. And that's the thing about, we should talk about measles and vaccines, but that's another talk. Anyway, so Dr. Bruton looked at the child, and saw that he had no measurable immunoglobulins, and he gave him subcutaneous immunoglobulin that he had. So the very first treatment was not IVIG, was sub-Q gamma globulin. So it's interesting how we've come full circle. Anyway, so what is XLA? It's X-linked, which means that it's on the X chromosome and it's passed on to little boys by their moms, and we'll have some slides down the road to explain that a little bit more carefully. It's the absence of B cells, and B cells are what you need to make immunoglobulins and antibodies. And because there's an enzyme that's missing, you can't make those B cells. So people present with literally no immunoglobulin levels that can be measured. No IgG, no M, no A, usually not IgE or IgD either. And because of this failure to make B cells, you can't make antibodies. You can give all the vaccines you want. You can expose people to all the germs that you can. They just can't make an antibody response, so they can't protect themselves against those kinds of illnesses. It's important to know that it's a disease of the humoral system or the B cells. All the other parts of the immune system are intact for the most part for all patients. So, you know, when we get those phone calls, well, I have to see the immunologist right away because I have no immune system. Really? Not true, probably. There's a piece of your immune system which doesn't work, but it's a nice system because it has multiple parts, and usually a single part is affected unless you have significant other kinds of diseases. But in this disease, XLA, it's an antibody disorder, and only the arm that includes the B cells is affected. All right, so the incidence is very rare. I know that you're all sitting here thinking, well, how come I got so lucky? But it's generally figured to be about 3 to 6 people in a million boys. It's important to know that it's usually diagnosed not at birth. This is not something that's picked up by newborn screening, which is the current buzz. Everybody's talking about newborn screening, and we're finding some immunodeficiencies now with newborn screening that we couldn't find before or didn't find before. But this is not picked up with newborn screening because the lymphocytes counts, which is what's picked up with the newborn screening, is usually fine. So usually it's diagnosed after the IgG that the infant gets from the mom is gone. And this is an old graph, but you can see that when a baby's born, the IgG level is high, and then as they get older and they come down to about 4 or 5 months, all that IgG starts to go away because that's the maternal IgG, which has waned. And then the child's own system, in a normal system, should kick in and make immunoglobulin. Well, in an X-linked, you've got that high peak when the baby's born, and then it comes down and it just stays there because the little boy can't make immunoglobulins. There's also, and I don't know if anybody here in the room, Agammaglobulinemia that's not X-linked. There's a bunch of mutations that cause problems with the enzyme to make B cells, and these patients also have Agammaglobulinemia. So I know I have 2 of these patients, and I don't know if anybody in the room has one of these disorders, but they present very similar to XLA, and we kind of lump them all in that Agammaglobuline kind of pool. The incidence for that is about twice as rare as XLA, but there are some patients out there. So it is possible for a girl to have agammaglobulinemia. I know because I have 2 of them. And I think, yeah, I'm going to turf it to Marc.
Okay, thank you.
We haven't exactly worked out the back and forth.
Yeah, we're just randomly trading off. So. It keeps us on our toes, right? You don't know when you're coming up. I'm going to use this mic if you can hear me because I don't like to stand still. You've heard a little bit about who gets XLA and a little bit about how that happens, but what I'd like to do is drill down a little further on the details of what we know in terms of the cause. So here you see a slide of sort of a broad overview of the immune system, and as Dr. Younger already said, the immune system is obviously complicated. There's lots of components to it, and it does a pretty good job of overlapping, of trying to cover when there might be a weakness in another area. So you can see, I'm not going to cover all of this, we'd be here all day, but you have these stem cells that can become really anything. Some of those become neutrophils down here, or what we call macrophages. Some of these become T cells, which are kind of the quarterbacks and do a lot of the directing of the immune system here in the middle. XLA, as she already said, is really specifically a problem with the B cells. And so that's the top line up there where you can see there's a lymphoid precursor cell that becomes a pre-B cell, and then ultimately over a series of evolutionary steps becomes a mature B cell, and then finally becomes a plasma cell. And plasma cells are what really are the antibody machinery of the immune system. So you can see plasma cells make different types of IgG, they make IgA, they make IgM, and they can make IgE to cause allergy problems. So what we're really seeing with XLA through a lot of research that's been done is that's where the breakdown is in that system from a pre-B cell out to a plasma cell that actually effectively makes antibodies. And that's where that red X, I'm going to tell you more about that red X, but there's a breakdown at that point in the system. So as you heard, the physician that discovered this was Bruton. He actually practiced right in this area, right at Walter Reed here, an Army physician. And he at the time wasn't able to discover that it was this protein, but he in the 1950s, as you heard described, there was this problem in a young boy. And you can see it took until 1993, so it took about 40 years for scientists to pinpoint where the problem was in terms of the development of these B cells. And what they honed in on was something that's now called Bruton's tyrosine kinase, named after the physician who initially recognized the condition. So we call it the BTK protein for short. And it turns out this protein is an enzyme that's essential for B cells to actually differentiate, to survive and become those plasma cells that produce antibodies. And so when we suspect this problem, we can diagnose that. First of all, you see lack of B cells. So you have a young boy, or I have a couple autosomal recessive too, doesn't have to be a boy, but you get a child, usually a boy, that has lots of infections, usually in the first couple years of life. You can see that the B cells are missing, they're not there. But then to confirm that this is the problem, you can actually look for the protein, the BTK protein. These days, more often, we just sequence the gene, and you can see that there's a problem in the way that the gene is put together, that it's not able to make this protein. And so this is just a simplified diagram of what we've been talking through. We know there are some problems with if you're missing the BTK protein and going from a pro-B cell to what's called a pre-B cell. But really the problem is those pre-B cells never mature. They never grow up to become B cells that actually can make antibodies. And so that, where that black bar is, that's the breakdown if the BTK protein is missing, which happens due to a variety of mutations. As you heard, for XLA specifically, this protein is found on the X chromosome. And I'm going to show you in a second. We know, women have 2 X chromosomes, men have an X and a Y. And so because males, boys, only get 1 X chromosome, if you have a problem with that X chromosome, for instance, a mutation in the BTK protein, you have no backup. And so that will cause a problem in what we call X-linked conditions. So as you can see, there's lots of genes, of course, on the X chromosome. That just shows you where the BTK gene sits. And this is just to sort of show you how this works. So we all know that when a child's conceived, you have a set of genes from the mother and you have a set of genes from the father. And so the mother has 2 X chromosomes and the father has an X and a Y that can be donated to the child at the time of conception. So here you can see if the red X is the one that has this BTK mutation on it. In this case, a girl is conceived and you can see she has the affected gene and she has a normal gene on the other X chromosome. So we call that, she's going to be a carrier for this. But because she has the extra X, she's not going to have any problems. She's got another gene to sort of back up the problem that's in that red X. You could also have the instance where a girl gets 2 good genes, a normal X from the father and a normal X from the mother, and she's not a carrier. So there's no risk of that woman passing down the gene further in the family tree. And then we come to the boys that are conceived. So here, of course, the boy gets a Y from the father, that's what makes him a boy, and an X from the mother. And if he gets that X that has the gene, the X-linked mutation on it, this is a little boy that's going to have Bruton's. Because he doesn't have another backup X like a daughter would, okay? But it's also possible that the X that comes from the mother is normal. He gets the Y from the father, and that little boy will not have Bruton's and will have no risk of passing that down further. Okay? Does this make sense? There'll be time to ask questions, but I just want to make sure. This is important because this is how we do genetic counseling, of course, right? We can actually, once we know that it runs in the family, you can actually test for this in various people, and you can say to a woman, yes, you carry this or you don't, which means if you have a boy, there's a 50% chance they will have Bruton's or X-linked Agammaglobulinemia. All right. The other type that Dr. Younger told you about was this autosomal recessive type. And this is a little more complicated. I'm not going to belabor it because it's fairly rare, but there may be people in the room that are affected by this. So autosomal recessive means that it can affect men or women, boys or girls. So it's not determined by the gender. But recessive means that you have to get 2 of the abnormal genes in order to have the condition. So if you have at least 1 normal gene, you'll be fine. You may carry that and you could pass it down. But so here's just, if this, for instance, we have 2 carriers. We have a father with a normal gene and an abnormal gene, and a mother with a normal gene and an abnormal gene. The little d is the abnormal gene. And so again, the way that genetics works, you have sort of these 4 combinations that can happen. You can get 2 normal genes. You can get 1 normal and 1 abnormal, and there's 2 ways that that can happen based on mom and dad. And then you can have 2 abnormal genes. Of these different options for the children, only this one will have the condition because they got both abnormal genes from each parent, okay? This is a normal patient, no problem with their antibody production. These are normal people, no problem with their antibody production, but they carry that recessive gene. And so again, that's something that, you know, if you see this showing up in a family, we like to counsel about that if you're a carrier and you have a child with someone who's a carrier, there is a chance of having this autosomal recessive agammaglobulinemia. Now it's rare, right? We don't see it very often because the possibility of this actually happening out in the population is quite unusual. But again, if we see a case like this and we make a diagnosis, that's where ideally we talk to the family and we start to do some testing to see if there are other people that carry this and should know about it. And then lastly, again, I'll go through this quickly, but this case is just, there's only 1 parent. In this case, it's the father, but there's 1 parent that has the abnormal gene. And you can see in this case, really, there's no chance that the child will have the condition. Because remember, for recessive, you got to have 2 abnormal genes. So none of these children would ever have two abnormal genes because mom has two normal ones, but you could have two carriers here. And so those are hard to pick up because you don't see people that have any problems. They're just carrying this gene silently, and they actually have to have a child with somebody else that has the same carrier status in order to have an affected child that has antibody problems. I'll say one last thing, and I don't have any of these patients. I don't know if you do this. There's actually very, very, very rare cases of autosomal dominant agammaglobulinemia. There's been 2 families described, I think, recently. And a dominant gene, we're not going to cover it, but a dominant gene means you only have to have 1 copy to have a problem. So that's unlikely to affect anybody just because it's so rare. But the point is that there are different genetic variations, different ways that this can happen as we look at families. And so just to sort of wrap up some of the genetic talk, the other thing that's interesting to know, and it'd be interesting to hear from you all, we know that about 40% of people that are diagnosed, again, mainly boys that are diagnosed with this, have an affected family member. So they're not the first ones. There have been other males in the family that have had this problem. But that means about 60% of boys born with this, it's spontaneous. There's no other family history. And so that's part of the reason we try to get out and talk to other clinicians. If you see a small child, especially a small boy, that has antibody problems, you have to think of this. You can't say, oh, well, it didn't run in their family, it's not genetic. These genetic conditions are spontaneous, in this case, more than half the time. And so, again, we think that that's passed down in the fashion that I told you about, but it has to start somewhere. And the issue there is, of course, you've got to diagnose these kids as early as possible. We'll talk about treatment in a second. And we know that if there is no family history, if you're not thinking of it and not looking for it in the medical setting, these boys are delayed at a later age. So they go sometimes 5, 6, 7, 8 years without getting diagnosed, and they're getting sicker and sicker during that time. So we always ask about the family history. It's helpful, and the studies show, yes, people are diagnosed earlier if we know of the family history, but we can't forget that this happens spontaneously, and not having a family history doesn't exclude this as a possible problem. And for the last little part of my section, let me just very quickly tell you how this happens at the basic level. So you're hearing a lot of talk about genetics at this meeting, rightfully so, because we're moving into an era where more and more genetic testing is being done and probably helpful. So just remember, we all have DNA, right, in our cells. We have these long strands that are wound up. It's interesting, if you took the DNA in one cell of your body and laid it end to end, so it's microscopic, right, but it'd be about 2 meters long for one cell. So you have all this genetic information in your body. That information, what are called base pairs, or nucleotides, get transcribed into RNA, and RNA actually builds the protein through a series of amino acids that get produced by your cells. So DNA becomes, of course, protein, and so that's where in XLA, that DNA that codes for the BTK protein is supposed to make this protein that's important for B cells to develop. Now, what happens with the mutation? Well, think of the DNA, the way that your body reads the DNA to make a protein as sort of spelling. I was pretty good at spelling, but I don't know, spelling can be difficult. And it turns out that there's a lot of things that can go wrong. It's complicated, that can go wrong when your body is reading the DNA and spelling it back in order to make a protein. So I'm not from Southern California originally, but I've lived there long enough to call it home. And so I've used this surfing as the word here that we're going to talk about. If there is a substitution, so one of the base pairs gets changed, you can actually change again the letter, so now you have surfing spelled wrong, or surging, which is a totally different word, right, a different protein. You can insert extra amino acids or base pairs into the sequence, so you have surfing with 2 F's, or surfering, another word. You can delete amino acids from a protein. So again, that's going to cause a problem with how the protein works. So now we don't even have the right word. I will tell you that in the BTK protein, and there's been over 500, well over 500 different mutations in that gene that I showed you. So it can happen in any number of ways. And most of the time when that happens, this is what happens. The protein actually gets shut off before it's actually produced the right way. So we don't have a complete word, and we don't have a complete protein at the end of the day. And again, that's what leads to these B cells just can't survive. They don't mature, and it leads to this, the lack of antibody production. So before I turn it back over to Dr. Younger, any questions at the moment? That either means you understand everything or really nothing at all. No. Okay. All right, well, we'll have plenty of time at the end, so I'll give it back to Doug.
So we're going to talk a little bit about a case study here because the test on genetics is coming afterwards. All right, so this is a story of a 2-year-old who actually presented at Johns Hopkins. This is one of my patients, came with severe bilateral pneumonia. You know, I don't know how many of your children or you in the room have had pneumonia, but normally pneumonia is in one place and not even in one entire lung. It's in a part of one of the lungs. It's pretty unusual to have it in both lungs at the same time. Not uncommon, but unusual. And that's usually a sign of, wow, is something else going on? Is there something besides pneumonia happening here? This is kind of, when I talk to other healthcare professionals, I talk about, you know, you're never going to find a primary immunodeficiency unless you look for it. And you have to recognize the signs. And I say, you know, there's some people that, you know, are waving little red flags, and then there's other people who have flashing neon signs across their chests. This is a kid that is vigorously waving a red flag, that maybe something else is going on here. So this is a little boy who, his first year of life was actually fine. He was actually in a large daycare, exposed to lots and lots of other little kids with schnobbly noses and GI distress and all kinds of things. He'd had ear infections starting kind of at his first birthday, and it was actually interesting. The mother always told the story. Yeah, he was sick for his first birthday party. It was a bummer. The whole family was here, and he was cranky and just wanted to sleep. That was his first ear infection. And he began to have more and more ear infections. He was treated, and it seemed like 2 days after the antibiotic course was finished, he had another ear infection. Chronically schnobbly nose. This kid was one of these all the time. Like, use a Kleenex, Tommy. He also had a bacterial skin infection multiple times. Again, as I said, this kid isn't just with the red flag. He's like starting to really get vigorous. And clearly there was something else going on here that we were missing. So we looked at his lab work, and his white blood cell count was elevated, as you would expect when people are infected. One of the first responses is the white blood cell, or the neutrophils, the polys as we call them. That count goes up, and that's usually the first sign that there's an infection going on. And as I said, there's lots of kinds of white blood cells, but the neutrophils, when you have a bacterial infection, that's usually the count that goes up. You'll hear people talking about a high white count, and that's what they're talking about. We looked at his serum immunoglobulins, and they were essentially unmeasurable. We couldn't find any IgG, we couldn't find any IgA, and the amount of IgM he had was just a spit. So this was a really significant finding for us. We then looked at his responses to vaccines. At the age of 2, he'd had 3 hits of tetanus, diphtheria, pertussis. This was pre-pneumococcal days, so he did not have a pneumococcal vaccine, but he'd had a Haemophilus influenza vaccine, he'd had a polio vaccine, he'd had 3 hits of all of those things. And he should have had antibodies to those vaccines that he'd gotten, and he didn't. He had absolutely no response, no indication that he was protected against any of those diseases. Then we went further and we did something called flow cytometry, which lets us look specifically at the T cells and the B cells and the NK cells, which is the talk for another session. But this kid had no B cells. So that gave us a diagnosis before we ever did genetics. And this was actually pre the days that we did genetics. Now we send out mutations all the time. There's multiple companies that do them. But in this day, there was a lady in Tennessee who would look at all the little boys' blood. We would send blood to her, to Dr. Mary Ann Connolly, and Mary Ann always helped us make diagnoses. I'm sure you've had people that Mary Ann helped you diagnose it. Dr. Conley was the go-to girl for all of us. Now there's multiple commercial genetic places on the market, and we can get the diagnosis relatively quickly. And for most of us, that's just a confirmatory diagnosis. We've got no immunoglobulins, we've got no antibody responses, we have no B cells, which are CD19 cells, so we're pretty confident we absolutely have a diagnosis. And Dr. Conley, at those days, helped us put the period at the end of the sentence. And now, as I said, the commercial genetics companies will do the same thing. And to go back to what Dr. Riedl was saying, that's important information, because genetic counseling and expectations, what you can predict about the future, is important. You know, the little boys are growing up and they want to get married, and they need to know what's the possibility of their offspring having these kinds of conditions. So with genetic testing getting bigger and bigger, genetic counseling is getting equally big. And the geneticists have become an intimate partner, I know in my practice, and I'm sure in yours as well. So let's talk a little bit about infections in patients with XLA. And this data is hot off the presses. This is the new IDF survey of 70 patients with XLA, and they shared the data with Marc and me for these slides. So this is unpublished data. You are the first people to see it. But these are the infections that people with XLA reported. About half of the people reported, well, even more than half of the people reported sinus infections. There were GI infections, there were eye infections, there were pulmonary infections. Virtually there were infections just of about everything. And that's the presentation of an XLA patient. In some other primary immunodeficiencies, there's a specific kind of infection that's a hallmark of the disease. For example, if you have a problem with your complement system, you normally see infections with a particular kind of bacteria. Those patients get septic frequently. But XLA, the entire spectrum of infections is possible. And this slide tells you that really nicely. And I'm sure if we did a poll around the room of the infections that your kids and that you had, it would be just as much polyglot. So the causes of infections for an agammaglobulinemia patient are usually bacteria, especially a particular kind of bacteria which carry a capsule around them, so they're called encapsulated bacteria. And those are things like pneumococcus, Haemophilus influenza, Pseudomonas, which is another gram-negative organism, another organism. Bacteria like Mycoplasma can cause these infections. Viruses, especially enteroviruses, are really, really problematic for people with XLA. And those are echoviruses, Coxsackie viruses, the hepatitis viruses. Enterovirus is really a huge player in the pantheon of XLA diseases. And then Giardia, which is a protozoa, also is problematic for people with XLA. So you can get lots and lots of different kinds of bugs. Do you want to talk about autoimmune inflammation? And then, sure. Right, then I'll go ahead and
So for a long time, I guess I'll speak for myself. I learned when I was training, longer than I like to admit now, that XLA was purely an infection. That was the problem, because it was just the B cells weren't working and you're missing antibodies. So all the things that Dr. Younger just talked about were the issue. And that if you could control the infections, people would do pretty well. And I think that's still true at some level. But what's become, I think, more prominent now, and this is, I guess, it's the good news, bad news, right? Boys with XLA are now living into adult life. It's actually very common, and we have data to show that with proper treatment and recognition and therapy, that there's no reason that these boys don't grow up and become men and live their lives. What we've seen over time now that they're living much longer is that maybe there are some other issues that show up. So you see here the inflammation and autoimmunity, and so we of course have seen this in other antibody deficiencies, for instance common variable immunodeficiency, which is a totally different type of immunodeficiency, but we see there that there are a lot of inflammatory problems. We didn't think that those happened as often in XLA, But now we're seeing that there are things like arthritis or chronic gastrointestinal issues that seem to be developing as people live their lives. And so this is, again, hot off the press in terms of other than infection. What other types of things do boys with XLA report? Or many of these are grown men. Do you know the age range of this? They didn't give us that, did they? Right. So I'm assuming there's a variety of ages here, but don't know that for a fact. And so you see things like fatigue, and fatigue is something, it's a tough one. We hear it all the time in immunodeficiency. I hear it in patients that don't have immunodeficiency, but clearly it's much more prominent in people with PID. And we're seeing here, this is well above the general population in terms of people that report fatigue as a problem. So that one's complicated. We're not sure exactly what causes that, but you can see other things. Arthritis, gastrointestinal problems appear to be more common than we thought in the past. And so somewhere between 15 and 20% of these patients are reporting those sorts of inflammatory problems. And then it drops off a little bit, but you can see, again, digestive issues, autoimmunity, asthma, and COPD, and then a smattering of other things. So it's probably not as simple as I learned 20-some years ago, that if you just treat with immunoglobulin, everything will be okay. I would say we're still sort of deciphering what sorts of signals are here. And the other issue that's become apparent is that despite a lot of evaluation, I can tell you, males with XLA don't always get a clear diagnosis as to what's causing these issues. So that's to say, if you have arthritis, they do they look for rheumatoid arthritis and all the other types of arthritis, and you don't come up with a clear diagnosis. So there's, people are having symptoms and not always, they don't always fit in the box, and that's no surprise to people at this meeting. Immunodeficiency doesn't fit in the box very well sometimes, right? You have a unique problem that's rare, and I think we're seeing that a little bit with trying to look at these inflammatory issues. That there may be unique things about XLA that we don't understand that cause these symptoms without saying, yes, you have rheumatoid arthritis, or yes, you have inflammatory bowel disease, just like other people that have inflammatory bowel disease. So that's kind of what this slide is getting at. Yes, it's not uncommon for people to have GI symptoms with XLA, to have fatigue or feeling, fevers and chills, to have arthritis symptoms. But again, as I said, only a small percentage of people, despite these symptoms, actually got a clear diagnosis of what was causing that problem. And so whether this is part of XLA, whether it's, what it's being caused by, I would say is very unclear at this point in time. So the take-home point here is that, yes, infection are the thing that we worry about the most. It's actually, I would say, the most actionable symptom. We have treatment, we have ways to deal with that, and we know that those infections can cause tremendous problems over time if they're not prevented or treated. But that being said, we probably don't want to exclusively focus on infection, and we need to take stock of some of these other symptoms that are starting to show up as males with XLA are living well into their adult lives and working and doing everything that we hope they're able to. Do you want to take over the treatment section?
Sure. Okay, so you have a diagnosis and you're dealing with it. What are the things that you need to think about? So the first thing is that it's just a condition, it's just part of your life, and you need to be taking care of the other pieces of your life. So in terms of general care, you absolutely need routine health maintenance. You need an annual physical with your primary care provider. If you're 50 or 60, you need that colonoscopy. If you're a woman, 40 or 50, you need that mammogram. All of the routine things are important. They're just as important for an immunocompetent person as they are for an immunodeficient person. Vaccinations are usually not necessary. I must get 10 calls a week from somebody that said, I'm at my primary care providers. They want to give me a Prevnar. Do I need a Prevnar? No, I've told you 100 times. You don't need a Prevnar. You don't respond to Prevnar. Don't let them give you a sore arm, because that's the only thing that vaccine is going to give you. So they do not necessarily need routine vaccinations. The exception to that is the flu vaccine. And the reason for that is a little bit funky. And the reason for that is because the flu strain that's around every year is a little bit different. And the vaccine is tailored to what the experts think is going to be the strain of flu around. Now, for those of you who get gamma globulin, the plasma for the gamma globulin that you give yourself today or that you received today was collected about 2 years ago. So that plasma reflects the antibody in that plasma is the antibody that was around 2 years ago, which may or may not be the strain that's around today. So we do recommend the flu vaccine. You guys do too, I'm assuming. We know that there's not going to be a B cell response, but we're hoping that there might could be a T cell response. And in my vernacular, I would say a spit of protection is better than none. Equally important is that your cohort, your family members get that flu vaccine as well. But that's the one vaccine that we tell our XLA and our Agammaglobulinemia patients to get. Live viral vaccines are absolutely contraindicated. So that's measles, mumps, rubella, and again, my phone's been ringing off the hook because we have measles in Baltimore my doctor says that I should get ahead of the measles vaccine. No, you should not get ahead of the measles vaccine. It's a live viral vaccine, and there's a possibility, very small, but that vaccine could give measles. Hopefully you have enough antibody from your immunoglobulin. You should have bazoodles of antibody, but a live viral vaccine is absolutely contraindicated. The interesting thing is that we talked about when these children were diagnosed. They're diagnosed as late neonates, early toddlers. They've already gotten 3 hits of the rotaviral vaccine usually. And sometimes these children do get a rotavirus infection, but we don't necessarily diagnose it with and know that it's rotavirus. We think that they've just got a GI and some diarrhea, a little bit of barfing, but so they've actually gotten the rotavirus. And there are XLA patients who've gotten an MMR and a Varivax because we don't diagnose them until they're 14 or 15 months old. So the possibilities that you could have a bad reaction or get the disease from a live viral vaccine is small. There's not a huge whopper dose of those bugs in the vaccines. They are what's called attenuated, but it is possible. And going forward, as I said, you do not need, all of my patients know you do not need a measles booster, trust me. And we've talked a little bit about genetic counseling, and that, as I said, that's become more and more important now that we have a better handle on how to get genetic results, on knowing what the mutation is, so we can tell people what they can expect and give them options. So treatment of XLA, obviously surveillance for infection. These are not, when your kid gets a fever on a Friday night and you call the primary care provider, this is probably not the kid you're going to sit on over the weekend and we'll see him on Monday if he still has a fever. This is something you want to jump on and take care of. And if you have an infection, they need to be treated appropriately and aggressively. Again, this isn't, well, let's just watch it and see for a couple of days. No, we're not watching. We're going to treat if we think that we have something we should treat. Immunoglobulin replacement therapy is absolutely key. People need the antibodies that they're unable to make for themselves. So these days we have lots of options for immunoglobulin replacement. We do IVIG every 3 to 4 weeks. And in that survey that we've been quoting, about a third of patients are still getting IVIG. You can do subcutaneous gamma globulin from every day up to every 14 days, depending on what you want to do. And that was about 2/3 of the patients that were surveyed in that. And then there's what's called facilitated sub-Q, which is kind of a combination of IV because it lasts a little bit longer, and sub-Q because you're giving it subcutaneously, so it kind of has bits and pieces of all kinds of facilities. There was no data from that survey, so we honestly don't know how many patients were getting facilitated sub-Q because the data was combined. So, but that's the third option. Yes, ma'am?
I've never heard of that. Describe it a little bit.
Sure. So it's gamma globulin. It's also, you give an enzyme called hyaluronidase. You give that subcutaneously before you give the gamma globulin. And what the hyaluronidase does, it sort of breaks down the collagen matrix in the skin and makes it possible to put a large volume. Those people who do sub-Q probably, depending on size, probably put 15, 20, 30 cc's into a site. It's possible to give a 3-week dose of gamma globulin, if you give the hyaluronidase, you make a bigger place to put a larger volume. So when it first came out, they said, well, we could do it you could get your whole dose every 4 weeks subcutaneously. Now it's kind of backed up a little bit, and most people are on this drug every 2 to 3 weeks. But it just allows you to give a larger volume subcutaneously through that product. It's a single product on the market from a single manufacturer. And as I said, I don't have the data. I don't know how many people are doing it. I know I currently treat about 450 people with antibody disorders. I don't have anybody on this product. But I do know of people out in the community that are on this product. Do you have any?
I have some, yeah, I mean, probably between 5 and 10% of my population uses that method. It's really, I mean, again, it's probably clear, all of these are effective, so you can't say one's better than the other in terms of efficacy. It's just a different way to do it, a little less frequently with a little more volume, and so it really comes down to how well, if that's what people rather do, how well they tolerate it. So it's kind of, it's individualized based on each person.
So do people, how do they feel about having a bigger site? I mean, my son's 15 and we do it once a week. I would love to have that.
Yeah. And that's one of the draws, is it's just simply less frequent, but you can still do it at home. It is a larger volume, as was said, that because the enzyme allows the immunoglobulin to spread out, I call it more of a pancake, so you don't get the big lump necessarily, but you do get the swelling. Yeah, it sort of spreads out, and in fact, a lot of my patients will do it on both sides just so they're symmetrical that way. So yeah, it's usually well tolerated. I've had a few patients try it who didn't like that much volume at once. So again, you kind of don't know until you try. But for people who really want to try to do it less frequently, it's something to consider.
I do that, and I like how it's more spread out, like once a month, but it is a lot of fun.
Right.
Thank you. It's nice to have somebody who does it, because I don't. So to get back to the infection and treatment, boy, I'm doing well today. Treatment of infections. So the goal is to prevent frequent or recurrent infections that might cause long-term organ damage, and that's really important. How many sinus infections can you have before you do damage to the mucosal surfaces of your sinuses? How many lung infections can you have before you do long-term lung damage called bronchiectasis? So the goal is to prevent those kinds of infections. And that's kind of the nice thing about this population, is that generally they're diagnosed early on. So they get onto therapy, they get treatment for their infections. So some of the things that you see in a CVID population who's taken a long time to be diagnosed, who's had a lot of infections and seen a lot of people, the XLA patients don't necessarily have that history of 11 years of infections, or 14 years of sinus infections, 3 sinus surgeries, da-da-da-da-da. Normally, it's not as big a deal for this population as it is for the example, the CVID population. But the goal is to prevent those frequent infections. When I start people on gamma globulin, I say, well, I'd love to sit here and tell you you will never have another cold. Not true. It's not going to prevent every cold. You certainly are going to get sick, but my goal is to keep you from getting so sick that you need to be hospitalized, or heaven forbid, you have a respiratory infection and you need to be ventilated in the medical ICU. That's the goal. Appropriate antibiotic therapy is important. And for us, it's always, are we treating with the right antibiotic? I just don't tend to throw antibiotics at people because it's the antibiotic of choice. Well, I like the pink color of azithromycin, so I prescribe it. No, I don't do that. I try to figure out what the infection is so I can treat it appropriately. And people always say, well, I needed the big antibiotic. I needed the really strong one. There's no such thing as a really strong antibiotic. It's just that every drug doesn't kill every organism. And if you've got an unusual organism, you might need an unusual antibiotic. But one isn't stronger than another. I think that's kind of a thing that people have in their head, is, I needed a really strong one. Not. It's the appropriate antibiotic. Yes, ma'am.
Can you kind of elaborate on how people would find out, or how their doctors would find out?
Generally, we always do cultures if we can get cultures. So if you've got a lung infection, as my partner says, you need to hock a loogie. You need to cough up a lump of stuff, and we culture that. It's the same thing as we send people to ear, nose, and throat doctors, and they look up the sinuses, a sinus endoscopy. You could just do that in the chair. You don't need to go to the OR to do that. And they get cultures of the stuff dripping down from the sinuses. Those cultures are key for us. We know what the bug is and what the bug is sensitive to, so we can tailor our antibiotic therapy. And that's really important for us. And when people come and they go, well, I went to urgent care this night, I went to another doc in the box this week, and I've been on 3 antibiotics and I'm not getting any better. Well, maybe because those antibiotics aren't treating the bug that you have. Let's figure out what bug it is, and then let's treat it appropriately. So that's important. I'm always getting cultures, if I can. You know, sometimes people can't cough anything up, but I also don't have problems sending people to get a bronchoscopy to get something from their lungs as well. Yes, sir.
Are you finding that males that are in their 30s now are becoming resistant to a lot of antibiotics and bugs, and that other things that might have been effective are no longer effective?
That's one of the reasons that I go for cultures. And you know, everybody talks about staph these days. It's kind of the ubiquitous bacteria that's around. Staph isn't susceptible to everything. There's the resistant staph, resistant to a lot of antibiotics. And sometimes with someone with a Staph aureus infection that I would think, oh yeah, this is absolutely going to take care of it, and I prescribe it and they don't get better, then I look at it and look at the sensitivity and find out that it was resistant to the particular antibiotic, and I change it. One of the reasons, and I think we talked about it in a couple slides later, is the question of prophylactic antibiotics. I don't tend to prescribe them in my practice, but I've sat around the table with other people who see lots of immunodeficient patients, and prophylactic antibiotics are one of their stocks that they do treat. My feeling in my practice with my partners that we think that breeds resistant bugs. And we really don't like giving antibiotics until we know we have something that the antibiotic is going to work on. So that's the waffly answer to your question, Rick. Generally, a regular course of antibiotics is fine. You know, people are like, well, I've been on this antibiotic for 3.5 weeks, and you haven't gotten better. Why are you still taking it? Whatever. Depending on what the infection is, should depend on the course. Generally, a long, prolonged course is not necessary. Occasionally it is, but it's important to figure out what you're treating and are you treating it appropriately. I knew that slide was coming right up. In that similar survey, almost a quarter of people were on prophylactic antibiotics. Again, it's something that really varies from practice to practice to practice. And that's the data from that survey. The important key piece, whether you're on prophylactic antibiotics or not, is that they don't take the place of immunoglobulin. You still need that immunoglobulin. That is the absolute mainstay of treatment of this disease. No matter what else you do, you somehow have to get immunoglobulin. I think, okay, so the important thing about immunoglobulin is that it's forever. Once you've got a diagnosis of Agammaglobulinemia, you're going to need immunoglobulin your entire life. So the important thing to do is to figure out how you're going to get it and how to make that therapy part of your life. So there's lots of decisions to be made. How are you going to do it? Are you going to do it IV? Are you going to do it subcutaneously? What's the product that you should use? Most of the products, well not most, but all of the products are equally efficacious, but they vary in the protein bases, in the concentration. So there's product choices to be made. What's the regimen going to look like? You can do subcutaneous gamma globulin every day, up to every 14 days. You can do facilitated sub-Q from weekly to every 4 weeks. You can do IV. I have patients that I give IV every 2 weeks to, up to every 4 weeks. So there's lots and lots of different kinds of regimens. And then where you do your infusion is another important decision. The important thing and the take-home point is that every decision should be made in collaboration. This is your therapy, it's your life, and nobody should be telling you what you should be doing. Someone should explain all of the options and let you make an informed choice. And the choice you make on Tuesday may not be the choice you would make on Friday. It's possible that as your life changes, that you're going to change the way you do your therapy. I have plenty of people that as little kids, they start doing IV because their parents don't want to stick them and do sub-Q. Well, then they start school and piano lessons and soccer practice and the travel lacrosse team here in Maryland, and all of a sudden, it's impossible to get that IV infusion. Well, that's when you switch to sub-Q. And mom does sub-Q. And my rule is that you have to stick yourself, the last chance you have to stick yourself is the night before you leave for college. Because you're going to college and your mother's not coming to your door and knocking on the door to do your infusion. All right, so that's my rule for when I start kids on sub-Q. No, you don't have to stick yourself until the night before you leave for college. But you change that regimen. And I had a kid that played D1 ice hockey for a school in the Midwest. And so, in addition to his academics, he was traveling to hither and yon for hockey games. And he changed his infusion every single semester that he was at college. You know, he would come to me and say, well, Dr. Beth, this is what my schedule looks like this semester. What do you think I should do? And I was like, well, what do you think you should do, honey? How do you think it's going to work? One semester he did his infusions during his Wednesday morning study group. Another semester he did them whenever. But the regimen changed all the time. And that's the important thing, is that you need to make those decisions and you're changing the regimen to make it work for you. Because it's part of your life and your life needs to be your life. So that's my soapbox issue. I see someone in the back row who's shaking her head like, have I heard this one before? I think I'm going to turf to you.
Great. So one last point I wanted to make about therapy is the monitoring. And of course, as you just heard, monitoring your immunoglobulin treatment is probably the most important single thing, making sure you're consistent with it, making sure it's working for you, you're tolerating it, all the stuff that Beth just talked about. But I would say the second most important thing is to keep an eye on the pulmonary system. We know that for antibody deficiencies, that the lungs are the target organ that takes the biggest hit because of the sinusitis, the bronchitis, and the pneumonia. And as we're seeing people with XLA living longer and becoming adults, this is something we have to keep track of because there may be some cumulative effects over time. Now, using the immunoglobulin treatment, we know helps prevent or slow any of these problems in the lungs, but it's not perfect. I mean, as you guys well know, doing the infusions is not the same as your immune system doing the job it's supposed to, because under normal circumstances, the immune system is very adaptive, right? It can learn, it can change, it can sort of fight things that come along its way. When you're doing the immunoglobulin therapy, it's good, it's very good, but it's basically dealing you a deck of antibodies every week or every month that you do it. And so you sort of have good protection, but not perfect protection. It's not the same level as if everything was working right with the B cells. So my point is that we still do see people get infections sometimes. We still do sometimes see pulmonary issues that will develop over years of having conditions like this. So I really encourage people, number one, if you have respiratory symptoms or your kids have respiratory symptoms, make sure you let your doctors, your specialists know about that. If they're wheezing, they're coughing, they're short of breath, they're coughing stuff up, it's important not to overlook that because we have to try to get to the bottom of that. The other thing that I think should be done occasionally, and it becomes, again, more important as people get older, is to look at the lung function test. In fact, I would say as soon as a kid is able to do that, it's good to get a read on it. Now, little tiny kids can't do you have to breathe a certain way, and so you have to start sort of when they're a little bit older. But that establishes a baseline, and that's something that we like to track over the years. You don't have to do it necessarily every year, but somewhere between every 1 or 2 years, I think, in my practice, that's what I recommend, unless people are having more significant symptoms. And then we do it sooner to see, has there been a change in the lung capacity, in the lung function, and in what's called the diffusion capacity, the ability of gas to get from the lungs, oxygen to get from the lungs into the bloodstream. So that's number one, lung function testing. This can usually be done either in the doctor's office or there's hospitals that have fancier labs to do more extensive testing if needed. The other thing is sort of, it's not required all the time, and that's CT scanning. Now, CT scanning has radiation involved, right? So we're not scanning everybody all the time for no reason. But what we get, if there are symptoms of coughing that doesn't go away, if there's sputum production that is not responding to antibiotics that are appropriate, sometimes this is worth doing. Because what we're looking for is this here. This is bronchiectasis, and this is damage to the lung tissue that we think happens from either repeated infections, or sometimes there will be a chronic infection that sort of sets up shop here with a bacteria that needs very specific treatment, and that can over time start to cause damage and scarring. And once you get scarring like this is basic. You can't reverse this. It's not reversible. You can slow it down. Again, we know immunoglobulin does that, prevents this, and if it's already present, it will, we think, slow the progression or the advancement of that. But this is important to think about for preventative purposes, and if it's there, it may require some additional, special, more aggressive therapy. So we hope not to see this in XLA, but I can tell you there are patients that develop this, and we want to know it's there because we may change the way that we're treating a person. I always tell my patients, you get one set of lungs, and we got to keep them healthy. That's not totally true because these days people do lung transplantation, but I got to tell you, lung transplantation with immunodeficiency is not a fun endeavor. It's, as you can imagine, you have to be on immunosuppressive treatments with the transplant. You already have a depressed immune system. It's real dicey, and people get very sick with transplantation of organs with immune deficiency. So anyway. The point is that we want to do everything we can to monitor and keep the lungs as healthy as possible. That starts with the right immunoglobulin treatment early and the right dosing and sticking with that. But there's some screening tests that should be considered if there are respiratory difficulties that develop. So I'll wrap up with a couple of comments, and then we can talk the rest of the time. As you all well know, we don't have a cure for XLA. The treatments we use are effective, fairly effective at preventing problems, but this is a lifelong condition currently. We've already talked about the fact that the immunoglobulin in particular may need to be adjusted over a lifetime, so it's not a sort of, here's your treatment, good luck, have a good life. It has to be monitored and adjusted. And then I get a lot of questions these days, rightfully so, about gene therapy. So it makes sense, right? This is a condition, I told you, we know where the gene is. We know what goes wrong with that gene and that's the cause of the problem. So why wouldn't we think about this for gene therapy? And the answer is people are thinking about this for gene therapy. There's a couple of issues related to gene therapy, and again, I think there's going to be a whole couple of sessions on this, so I won't try to cover it in detail. But the type of gene therapy that's actually being used in a couple of rare conditions now, it's been approved by the FDA recently, uses viral vectors, right? And I think the first session they talked a little bit about that. And these viral vectors deliver a gene to the cells, and sort of that gene then starts to do the job that the mutated gene isn't doing in a person's body. The issue with Bruton's, or XLA specifically, is that the gene that we're targeting controls B cell proliferation, right? B cell development and B cell numbers and so forth. And there's been considerable concern that if you get it wrong, if you deliver by a gene or by a viral vector a gene that you can't control very well, and there's a lot of questions about how well can you control the expression of a viral vector gene, that in this case you could induce way far overproduction of B cell activity. And what happens when that happens? Cancer, lymphoma. And so there's been a lot of, I would say, hesitancy or a sense of caution about charging in and trying that, because if you get it wrong, you may actually induce as big or bigger of a problem in terms of a malignancy with that type of gene therapy. So that's put a little bit of a damper on enthusiasm for viral gene therapy for XLA. The other type of gene therapy is gene editing. And again, you heard a little bit about that this morning. There's various ways to to generate machinery that will go in and actually repair a gene. You cut out the bad one and put in a good gene. And that actually may be a much more sensible way to go about this. Again, if you can develop gene editing therapy to just repair the BTK gene without fear of it overexpressing when you're putting a virus into the system, that actually may hold some promise. And I don't think neither one of us are aware of a company that's looking at that or an academic center that's doing that at the moment. But I can tell you it's on the list of conditions that people are thinking about for gene editing. And so, gene editing is a little bit further behind the viral gene therapy. But I think I would guess in the next decade, we're going to see people trying gene editing in humans for very specific conditions. I don't know whether XLA will be on that list or not, but I think there's hope that might be ultimately a way to try to cure this condition. And the last couple of things, we've sort of talked about this a little bit, but I would say, and I encourage my patients that, once you're on the treatment and we're monitoring, controlling for infections, we're doing all the things that we talked about, I think patients these days can absolutely do everything that they want to try to do. That's my take on it. You have to be cautious. You have to be smart about infectious issues. But I have a cadre of adult XLA patients or teenage and college-age XLA patients, and they're living, I hate the word normal, I don't know what normal is, but they're living a pretty normal life outside of doing their infusions. They have to plan for that. So they're going to school, they're traveling, they have successful careers. There's been a couple of studies looking at this in the last decade or so it's always hard to know if that relates to today. But it does show that the quality of life for XLA is good in general, that people with this condition, they miss a little more work in school than the general population. They end up in the hospital a little more frequently than the general population. But overall, that we've made huge strides in terms of making people able to do the things that they want to do. So it's certainly not perfect, but I think with the right treatment plan, the right specialists, we're really encouraged that this is a condition that can be controlled and doesn't have to influence people's educational or career paths. Do you want to add anything to that?
No, I just basically I think when you're making life decisions, no matter what your experiences are, you need to consider everything. When we talked, I have a patient who has not XLA but hyper IgM, and from the time he was a little boy, he wanted to be an electrician. I have no clue why that was important, but he wanted to be an electrician. He could envision his whole little shop and the people working for him and all the things that he was going to repair, and it just, for whatever reason, this was his life goal. And when he thought about it, and we talked about what he was going to do, and he realized that he was going to have to pay for his own insurance, and he was going to have to get an insurance policy that was going to pay for his immunoglobulin, and he was going to have to be self-insured. And he actually investigated what the cost of those kinds of policies would be, and he realized that his own little electrician shop couldn't begin to make enough money to pay for his insurance. So I will tell you, he is now a big-time supervisor at Baltimore Gas and Electric. He's absolutely an electrician, but he's working for a huge company that has fabulous insurance benefits. And that was something he had to think about, in terms of careers. I'd love to be a concert pianist. Unfortunately, I'm a terrible piano player. So I think I need to cross that off my list. But if I had a condition, I would have to think about. And so people do need to think about. Traveling is the other thing. We have a big travel clinic at Johns Hopkins that I send people to all the time. And there are some places that it's probably not really wise for people on immunoglobulin to visit. If you need to be vaccinated with yellow fever vaccine, we can't give you yellow fever vaccine. So if you go to an area or you want to travel to an area where yellow fever is endemic, we can't protect you. So maybe that's not the best place for you to go. Now, Lord knows there's plenty of other places in the world to go to, but sometimes you have to think a little carefully. But is that true for an immunocompetent person? Yeah, ladies who can get pregnant are probably not going to the Caribbean these days for reasons of Zika virus. But so whatever decision you make, you need to consider all of the circumstances that are part of your life and make appropriate decisions. It isn't just immunocompetent versus immunodeficient. Yes, Ms. Appleton.
This is related.
Yes, ma'am.
So I am struggling with students who want to study abroad. So my XLA students, they maybe want to go. I have a boy who had an opportunity to do a semester in Israel, and then another boy who had a chance to do a semester in Egypt. What creative ways have you used to get them there?
I have absolutely sent people. I had someone in New Zealand when there were earthquakes in New Zealand, and we couldn't find him for 3 days. And I kept emailing his mother, do we know where Jonathan is? Yes, we finally found Jonathan. And the New Zealand case was actually funny because New Zealand regulations say that you can only bring 3 months of a prescription drug with you. So I doubled his prescription. I changed his prescription and said instead of 6 grams a week, he needed 12 grams a week. So he took 6 months or 3 months of Agammaglobulinemia in his backpack. And I've done that. I had a kid travel the Australian outback over the summer and sent him to Australia with his immunoglobulin. I have not had problems. I've had kids, my college kids go all over the world. Matter of fact, I have one in Israel right this minute.
I would like to talk to you about that because we have some customs concerns with Egypt.
I send my patients who are traveling with their immunoglobulin with a letter that they carry in their breast pocket that says that they're under care for this condition. They're traveling with their medication administration supplies, and a pump, plus or minus. A lot of my people, when they travel, don't use a pump. They just push their immunoglobulin so they don't have to worry about the pump. But nobody's ever been stopped, and I actually have a lady, not an Agammaglobulinemia patient, but a CVID patient, who's an expert in international terrorism. So she travels everywhere. She does not travel to garden spots. Rome, Paris, London are not where she goes. She goes to Chechnya and Uzbekistan and places. She's been to Tehran a couple times. So she just, as I said, not exactly garden spots. She's never had a problem getting through customs with my letter in her pocket. So again, it's creative thinking.
Yeah.
Sometimes it's outside of the box, as Marc just said 2 slides ago.